and I'm going to talk about this hard topic and sometimes controversial. So the main goal in our patient with urolithiasis is, for one hand, to remove the stone, but for the other is the prevention of other episodes. So a metabolic workup led us to identify predisposing factors or diseases associated with urolithiasis. And the lithogenic risk of a patient is determined not only by the metabolic alteration, also by urine volume and urine pH. So in fact, the alteration most commonly found in our patients is the low urine volume. The changes in urine composition, as you know, is produced by an increasing of crystallization promoters like calcium, oxalate, phosphate, urate, and cysteine, and a deficit or a deficit of crystallization inhibitors, citrate and magnesium. Citrate inhibits the crystallization of calcium salts and forms soluble complexes with calcium, and magnesium forms a soluble species with oxalate ion. But one of the most important things is the stone analysis. Bernard will speak about this, and it's mandatory, it's crucial for the diagnosis to have a stone analysis if we have the stone. And the use of the crystalluria in diagnosis and treatment can become a routine part of care for the stone formers, because crystalluria provides an indication of the propensity for stone formation and as the probability of the stone recurrence and indicating if the treatment is efficacious or not. And as you know, we have the pathognomonic crystals of cysteine and 2H-DHA crystals. For patients, we have two evaluations for metabolic workup, the basic evaluation and a specific evaluation. The basic evaluation is for patients who have had a single episode of lithiasis and who undergo with non-specific prophylaxis with diet and increased fluid intake. This recur only in almost 60% of the cases in 5 years. And for the rest of the patients, we perform a specific evaluation for recurrent nephrolithiasis, persistent residual lithiasis, nephrocalcinosis, and children and young adults. For the initial workup, the patient should stay on a diet normal in daily conditions with a stone-free for at least 20 days. And the first follow-up, 24-hour urine, is suggested 8 to 12 weeks after starting pharmacological prevention of stone recurrence. And then when all the parameters have been normalized, it suggests to do the evaluation every 12 months. These are the indications of specific evaluations. As I say, recurrent stone formers, bilateral or multiple stones, nephrocalcinosis, solitary kidney, children, familial stone formation, renal insufficiency, lithiasis, uric acid lithiasis, cysteine lithiasis, extravasate lithiasis, and patients with endocrine, metabolic, intestinal diseases, osteoporosis, bariatric surgery. In our hospital, for the basic evaluation, we do these parameters in blood and in urine. In blood, we evaluate glucose, urea, sodium, potassium, magnesium, chloride, creatinine to check the renal function, uric acid, calcium, phosphate, And we do in the basic evaluation PTH, 25 vitamin D, and bicarbonate. We have in our population there are a lot of prevalence of deficit of vitamin of 25 vitamin D, and we have a lot of high PTH. And for a specific evaluation, we include the 24-hour urine with, it's important, the creatinine, the volume, and we find the inhibitors and these promoters of crystallization: uric acid, calcium, citrate, oxalate, phosphate, and magnesium. And we include proteinuria to exclude the damage in kidney. Some authors include or suggested to do a cysteine screen and at least one in patients with urolithiasis as well. And what type of urine collection is the best? Because 24-hour urine sample is the gold standard, but there may have false negatives. And as alternative, we have the spot urine samples that are more used by pediatricians. They use these samples in the first urine of the day and after breakfast, and the pickup is very easy. But there are limits because the results may vary with collection in time and patient sex, body, weight, and age. And as alternative, some authors defend the use of 12 urine sample night because it has easy pickup, include intake and fasting period, avoid false negatives in 24-hour urine, but like inconvenience, there are no specific values. For the 24 urine collection, the recommendations is 2 urine collections will be performed because the high within subject variability. We have to perform on a free diet and during a typical day, and we need simultaneous determination of fasting blood draw to interpret urine excretion in the setting of circulation values, because allows to calculate fractional excretions and calculate creatinine clearance. Fractional excretions is also more important in pediatrics patients. Respect to urine creatinine is not associated with risk of a stone, but is a measure to assess the adequacy of urine collection. This is, for example, the criteria of Mayo Clinic, and higher values means over collection and lower under collection. We have to check in a 24 urine sample, first the volume and then the creatinine to assess this adequacy of the collection. For the evaluation of hypercalciuria, we have to evaluate urine sodium. The higher the sodium blood, the greater the calcium excretion. A high sodium intake increases calcium excretion, urine pH, and decreases citrate excretion. Sodium intake causes extracellular volume expansion and inhibits tubular calcium reabsorption. And the urine sodium excretion is considered the most reliable method to assess sodium intake. The most appropriate sample is 24-hour urine, but in children, in non-continent patients, we can use the sodium-potassium rate. A sodium-potassium rate over 2.5 means a diet rich in salt and poor in fruit and vegetables. And for the other hand, urine potassium can be used a marker of diet potassium intake and to monitor the adherence to potassium alkalis. And how are ratios calculated? Because these ratios express the milligrams or milliequivalents of the substance to be studied that appear in urine per milligram of filtered creatinine. But it is based on the fact that creatinine clearance in the absence of renal damage should be constant. So, this one first. What happens with patients with renal insufficiency and the ratios? From early stages in renal insufficiency, we found hypocalciuria, hypositraturia, and urine concentration effect. Creatinine in urine decreases. So the ratios that use creatinine may be overestimated. So if you use these ratios, only are valid for stages 1 and 2 of CKD. So I changed the position. In metabolic workup in hypercalciuria, as I say, the gold standard is 24 urine sample for 2 in 2 days consecutive, in 2 consecutive days. But we can use the calcium creatinine sample in fasting and after breakfast. The values are established in the second urine of the morning. And it's important to evaluate the citrate in 24 urine sample or in ratio. Citrate creatinine ratio have a good correlation, but they can't interchange. And I'm going to point up in the calcium citrate ratio. This ratio is widely accepted as a marker for the risk of crystallization of calcium salts, regardless the age, the time of sample, the type of collection, and the time of the day. Dr. Guimera spoke yesterday about distal tubular acidosis. We have to suspect it when we have a patient with hypercalciuria, hypositraturia, nephrocalcinosis, urine pH over 5.8, normal blood bicarbonate, normal or low potassium, with calcium phosphate stones without infection. And for me, it's important these 2 algorithms that I'm going to talk about them. In the hypercalciuria algorithms, when we have hypercalciuria, first we have to rule out hypercalcemia and high PTH. When we have normal calcemia, we look to the potassium. If the potassium is low and there's alkalosis, we will think in Bartter syndrome. Or if we have low potassium and acidosis and no complex tubulopathy in a infantile tubular acidosis. But these entities are pediatric entities and will be diagnosed by pediatricians. Most important is this chart when we found hypercalciuria with normal calcemia and normal potassium. We have to look the blood test. If we find hypomagnesia, a very low magnesium, maybe we have a familial hypomagnesemia and hypercalciuria and nephrocalcinosis entity. If we have a low phosphate in blood, maybe we have a hypophosphate rickets with hypercalciuria. If we have a low uric acid in blood, maybe we have this tubulopathy, hyperuricemia, hypercalciuria syndrome. Or if we find proteinuria, maybe it's a disease, a den disease, like Dr. Trincheri spoke yesterday. It's not normal. If we don't have renal insufficiency, it's not normal to find proteinuria in our patients. And if everything is normal, we find the idiopathic hypercalciuria. A few words about uric acid stones. The study is aimed to rule out metabolic syndrome and evaluation uric levels in blood and urine. And uric creatinine ratio is not good. No, it has not good correlation with 24-hour urine. In the case of urine oxalate, we have to do the two determinations of oxalate in urine and to roll out the different types of hyperoxaluria. We have to do these determinations with or without oxalate restrictions. Primary hyperoxaluria, the diagnosis is made after ruling out these secondary causes. In fact, in the recommendations, the clinical practice recommendations for primary hyperoxaluria for Oxal Europe, when we find an adult with recurrent lithiasis, with more than 2 kidney stones or nephrocalcinosis, we have to evaluate the oxalate, the hyperoxaluria. We have to rule out the diet and the enteric causes, and then we have to perform a genetic test. Regarding to the oxalate creatinine ratio, allows an initial patient screening, and if it's altered or the result is close to pathological limit, or the clinical suspicion of hyperoxaluria is very high, we have to do the oxalate in 24-hour urine. Only to conclude is the importance of urinary pH. I think Dr. Siener and Dr. Bernat will talk about this, and the urinary pH is especially important for uric acid stones, cystin stones, and infection stones. And to conclude my presentation, metabolic studies are necessary not only for diagnosis, but also to evaluate the response to preventive measures. Most stones are a mixture of various components. In some cases, there are no metabolic alterations because there's inadequate urine collection, because there are modifications of diet and lifestyle of the patients, not withdrawal of the medication potentially lithogenic, or the clinical episode is very recent. The basic study in an isolated episode in an adult patient, extended a specific study for the remaining cases, recurrent disease, nephrocalcinosis, and young patient. And I want to point out the utility of urine spots. Thank you.